Welcome to the inaugural PrecisCa Virtual Breast Cancer Tumor Board. So happy and honored to have our August panel here. I'll introduce them one by one. In fact, they will introduce themselves. First, Dr. Tari King from Harvard.
Thank you. Hi, I'm Terry King. I am the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I enjoy taking care of breast cancer patients, and particularly the multidisciplinary approach that we're able to take, and I'm happy to discuss these cases with you today.
Hi, my name is Tom Buckles. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego. I have been at MD Anderson in Houston as a radiation oncologist for 20 years, and I specialized in breast cancer. And love to participate with my multidisciplinary colleagues in the management and research of breast cancer.
Hi, I'm Dr. Bill Gradisher, professor of medicine and chief of hematology oncology at Northwestern University, where I've been for the last 30 years. And I also, along with my colleagues, enjoy taking care of breast cancer patients and the challenges that come with understanding the nuances with each and every case.
Hi, I'm Rennie Butler. I'm Associate Professor of Diagnostic Radiology at Yale University School of Medicine and on the medical faculty of Yale New Haven Hospital and Smilow Cancer Hospital. Looking forward to participating in this panel. I really appreciate the multidisciplinary perspective, and I look forward to presenting the imaging findings, which are really a rapidly evolving technology. And so we'll be discussing how that technology can hopefully be more and more helpful as time goes on.
I welcome all of you, and let's get right to it and start with our first case. Dr. King, tell us about your patient.
Thank you, and thank you for this opportunity this morning. So this is a 50-year-old perimenopausal female who presented after she felt a mass in the upper outer aspect of her breast. She had a mammogram and ultrasound, which confirmed the lesion. She was clinical T2N0, and ultrasound biopsy demonstrated infiltrating duct carcinoma, grade 2, ER/PR positive, and HER2 2+ by immunohistochemistry, which was confirmed positive by FISH. She heard a discussion of the treatment options, both local management as well as systemic therapy, and she was desirous of mastectomy. She wanted to avoid radiation, and therefore we planned to proceed with upfront surgery.
So before you go any further, Dr. Butler, you see an image here.
Sure. So this is a standard MLO view, which is one of the two standard views we perform for screening mammography.
Does it stand for medial, lateral, oblique, like you're coming from an angle from inside out?
That's exactly right.
Okay.
The breast is compressed from side to side at a slightly oblique angle, with the intention to include the low axillary portion of the breast, where sometimes breast tissue extends. And the MLO acronym refers to the direction of the X-ray beam as it travels through the breast tissue. So it stands for medial, lateral, oblique. And Dr. King has very nicely outlined the abnormality. If we look inside the circle, we can see that there is a mass which has spiculated margins, meaning that they extend outward like sort of hair-like projections away from the center of the mass. That's a very suspicious feature. It's the single most predictive feature of malignancy. So when we see a spiculated margin, we have a high suspicion that it's breast cancer.
Here we see some pathology. Dr. King, you want to explain that? And we don't have a pathologist in the room.
Sure. So as stated, we proceeded to mastectomy. At the time of mastectomy, she underwent a sentinel lymph node biopsy. So the sentinel lymph nodes are the first nodes that drain the breast, and we identify those lymph nodes in order to determine the stage of the remaining axillary nodes in the axilla. And so on her pathology, she had a 2.1 centimeter intermediate grade infiltrating duct carcinoma. Some portions of the tumor were grade 2, some were grade 3, a little bit of heterogeneity there. There was no lymphovascular invasion in the mastectomy specimen, and she had 1 of 3 positive sentinel lymph nodes. And this photomicrograph, this is a picture of a slide that the pathologists make when they're processing breast tissue and they look at the slide under the microscope. This is one of the pictures of the node, and the arrow is pointing to the deposit of metastatic disease, which is in the more pink color in the background of the lymphocytes, which are the darker blue cells in the picture. And so this is just an example of the breast cancer has traveled to 1 of the 3 sentinel lymph nodes.
So the concept you explained of the sentinel lymph node, is it like if you have a reliable receptionist in a building and somebody's looking for someone, they just ask the receptionist if they are in the building and not have to go room to room to search the building? Is that the concept of sentinel lymph node sampling?
That's a nice analogy, one that I have not used before. I usually explain the concept of sentinel lymph node as the sentinel lymph nodes are sort of the guards or the gatekeepers for all of the lymph nodes that a woman has under her arm. Most women have 2 to 3 sentinel lymph nodes, or 2 to 3 guards. And so we identify those lymph nodes by injecting usually 2 different tracers, we call them, or dyes, into the breast parenchyma. And then those tracers travel through the lymphatics up to the lymph nodes, and they stop in the sentinel lymph nodes. So we then can identify them by identifying these tracers. One tracer is a blue dye, so it actually turns the lymph node blue. The other tracer is a little bit of radioisotope, so we detect that with the small gamma probe in the operating room. And we just remove those first, usually 2 to 3 sentinel lymph nodes to be assessed microscopically for the presence of metastatic disease.
So if that is negative, you say with a high degree of confidence that other lymph nodes are not involved. And what are the odds of missing another positive lymph node if sentinel lymph node is negative?
Yes, so we know that the procedure itself, although it is highly reliable and accurate, that it does have what we call a false negative rate, which means what is the likelihood that the sentinel node is negative, but there is in fact disease left behind in the axilla. And that false negative rate ranges anywhere from 5 to 10%, depending on the clinical scenario and the clinical trial that is reported. And initially, when we adopted this technique, that was a little worrisome. We were concerned about what the consequences might be of leaving disease behind in 5 to 10% of women. But we now have very nice long-term data from multiple clinical trials demonstrating that axillary failure, or cancer growing or returning under the arm, is exceedingly rare in women who have their sentinel lymph node biopsy and are staged as node negative. So even though there may be cancer left behind in up to 10% of patients, the rates of having axillary recurrence are actually below 1% or maybe approaching 1% with long-term follow-up at 10 to 15 years. So the procedure, again, is felt to be highly reliable and accurate, and even in cases where they might be disease left behind, that disease does not appear to become clinically apparent or impact the patient's overall prognosis or long-term outcomes.
Dr. Buchholz, from what you hear so far, what are you thinking as a radiation oncologist as to what's your role in this case and what would be the options and how they would change with your involvement in upfront decision-making?
Well, thank you. This case really highlights the importance of these tumor boards and the importance of multidisciplinary interactions. Radiation, like surgery, is considered to be a local regional treatment. That means we use radiation specifically in one area of the body, and we direct the radiation beams very precisely to include volumes such as after a mastectomy, treatment of the chest wall or where the breast used to be, in addition to treatment of lymph nodes that are not removed. Sometimes even when you do a more extensive lymph node dissection, there still will be lymph nodes that get into areas that are challenging to approach surgically, like lymph nodes up by the collarbone or there are some lymph nodes relevant to breast cancer called the internal mammary lymph nodes that are actually inside the chest. And so radiation sometimes can be a natural complement to surgery. We work together to make sure that all the disease in the breast and in the lymph nodes and in the soft tissues around the breast are eradicated. Dr. Gradishar will talk about systemic treatments, but this case, again, I think we have some various options here. We know that there's a positive lymph node that was unexpected. Sometimes when you have this subtype of breast cancer called HER2 positive breast cancer, it's a more aggressive biology, and we find that prior to commencement of treatments, that it can also be a little bit more extensive than we had anticipated. So I would consider this case to now be a stage 2 breast cancer with at least one positive lymph node. I think both Dr. King and myself would feel that we need additional treatments of the remaining lymph nodes. And it would be a question for both of us as to whether additional surgery is going to be needed to remove additional lymph nodes, or whether we should just target radiation to treat those lymph nodes. And so this is a interesting case. Historically, radiation has been shown to be of significant benefit when patients have 4 or more positive lymph nodes. And more recently, the clinical trials have indicated that even when you have just 1 to 3 positive lymph nodes, in many cases, they'll benefit from the addition of radiation after surgery. With this HER2 positive breast cancer, we think that because the biology is more aggressive, that we should treat it more aggressively with more comprehensive treatments. Now, the good news against HER2 positive breast cancer is that Dr. Gradishar has such highly effective systemic treatments, and those treatments also help to minimize the risk of disease that might be present in remaining lymph nodes. But I think the first question that Dr. King and I would be addressing together as to whether additional surgery is needed, and the additional surgery would be what's called a completion axillary dissection. We talked about that when the sentinel lymph nodes are negative, that the risk of additional disease within the lymph nodes is really quite low. However, when the sentinel lymph node is positive, as in this case, there's still a significant chance that if you go back and remove additional lymph nodes, you'll find some. So I think I'll turn it back to Dr. King and get her thoughts as to whether she feels compelled to do additional lymph node surgery. And if so, how would that influence subsequent decisions concerning radiation? She might say that, well, if you're going to do radiation anyway, why don't we just use the radiation to treat those additional lymph nodes that I've removed? But why don't I turn it back to Dr. King and get her thoughts as to whether she was considering doing a completion axillary dissection.
Thank you, Dr. Buchholz. So absolutely, these cases do require multidisciplinary discussion, and we know that that this patient does have different options based on the results of very well conducted clinical trials that give us these options and the outcomes associated with these options. So this patient, as you stated, with having 1 positive sentinel node, based on these clinical trial data, we would estimate that she has about a 25 to 30% chance of having additional disease in the axilla. And the options, as we know, for managing that additional disease are either completion axillary node dissection or targeted axillary radiotherapy. And both of those options are associated with excellent long-term local regional control. And both options, unfortunately, also have side effects or comorbidities, the most concerning one for women being the development of lymphedema. And in the landmark trial that really demonstrated the difference or the safety of both node dissection and radiotherapy, the trial goes by the name of AMAROS, rates of lymphedema were lower in the women who were treated with axillary radiotherapy as opposed to completion lymph node dissection. And so these can be quite nuanced discussions that we have with patients, sort of weighing both the risks and benefits of the treatment options. As you stated, there certainly is survival benefit to post-mastectomy radiotherapy for many women with node positive disease. But whether or not a woman with a single positive node needs postmastectomy radiotherapy or not can be a bit controversial. And so the way we would handle this is, if you felt that this patient already had enough risk that you were planning to recommend postmastectomy radiotherapy with the information that you have, then I would defer lymph node dissection. If you felt that the one positive node in this 50-year-old perimenopausal woman who also has ER/PR disease and has not received any systemic therapy, if you felt that one positive node was not quite enough to push you towards recommending postmastectomy radiotherapy, then I would favor dissecting the axilla, and that additional information, would then obviously be used in her subsequent treatment decisions.
Yeah, I just want to completely agree with what Dr. King has said. That's exactly how my approach would be. Sometimes cases like this, there isn't 100% correct answer. I think these are the types of cases where engaging the patient already, we heard that one of her reasons that she did not want to have breast conservation was some fear of radiation. I would want to educate her that she needs not to be overly fearful of radiation. While it does carry some side effects and risks, the advances in our treatment have made radiation very safe. And that's, of course, there's going to be some side effects. One of the biggest side effects after mastectomy that is radiation could have a negative impact on a potential reconstruction. So if she had an implant-based reconstruction, that could have a poor cosmetic result long-term if she did indeed require radiation. This is one of these borderline cases in my own mind. She has a lot of effective systemic treatments. And if she were to receive both hormonal therapy and anti-HER2 therapy, and possibly even chemotherapy, then I think that would put her in a relatively low risk if indeed this were her only positive lymph node. So if she did not want to receive radiation, I think proceeding with additional surgery and customizing, and hopefully not needing radiation, but customizing based on the results of that would be appropriate. If she said, I'm not going to do additional surgery, then I would say, yes, we do need to do radiation. And even if she did have additional surgery, like Dr. King said, there's a 25% chance or so she might have additional lymph node disease. And if that lymph node disease becomes not just one positive lymph node, but 4 more positive lymph nodes, we're still going to require radiation, or we're still going to be recommending radiation. Because again, radiation, this is good news. Radiation helps to improve the overall cure rate, in addition to the benefits that she's receiving from surgery, and in addition to the benefits she's receiving from her systemic treatments. So I think this is going to be something that I would probably ask to see the patient in consultation and go over the risks and benefits of these complex decision-making.
This is excellent discussion on local therapy. We all know that surgery and radiation work where they are done or given, but mostly cancer takes lives by spreading to far off places. We have to do something to cleanse the rest of the body. So where we bring in a medical oncologist, we are really talking about known, suspected, or feared spread of the disease. So with that, I will ask Dr. Gradishar to enlighten us on systemic therapy option or total body treatment options for this patient.
Sure. So I think it's already pointed out, we have concerns not only about local recurrence, but what is more life-threatening, obviously, is systemic recurrence, something that occurs at a distant site in your body. So if the disease shows up in the lungs or the liver, then we're dealing with metastatic disease, which is treatable but not curable. So typically, what we try to do is provide a systemic therapy that goes everywhere. And I should say at the outset that when we think about the risk of recurrence, at least systemically, in a very simplistic way, it's based on the volume of disease. So by that, I mean, when you take into account the size of the tumor in the breast, or whether there are no lymph nodes or 10 lymph nodes, it's the volume of disease as it increases that puts you at a heightened risk of having micrometastatic disease somewhere else. And by that, I mean disease that got away into the bloodstream or disease that entered the lymph channels. So although this patient had a single lymph node that was positive, there are circumstances where the nodes are negative, and we still see the development of metastatic disease, highlighting the fact that the disease, the cells, can get into the systemic circulation, lodge somewhere, sit there for years and do nothing. So when we're treating a patient with early stage disease such as this one, we want to do everything we can, both locally and equally important systemically, to reduce the risk that the disease would come back at some later date. So that's why we try to optimize both local and systemic therapy. In this patient, we also look at the molecular characteristics of the tumor, which help define not only risk and behavior, but they help us tailor the therapy that we would recommend to a patient. So in this case, the patient was both what we call hormone sensitive or having estrogen receptors, and also HER2 positive. So these are two strategies that we can leverage based on the molecular markers that are present to define the best therapy. So typically, when we see HER2 positive disease, especially when it's node positive, we would consider a combination of chemotherapy and what we refer to as HER2 targeted therapy. And these are oftentimes antibodies that are given in conjunction with chemotherapy, at least for the short term. So in other words, we often start out with a cocktail of drugs that include both chemotherapy and anti-HER2 therapy. The duration of the chemotherapy is much shorter, and the anti-HER2 therapy continues beyond that, typically for a full year. And drugs that we commonly combine with anti-HER2 therapy include a class of drugs we call taxanes, or platinums, or even anthracyclines. There are very set regimens that have been demonstrated to have benefit in this setting. The typical anti-HER2 therapies that are combined with chemotherapy are usually drugs like trastuzumab. Commercially, it's referred to as Herceptin. In certain circumstances, particularly as the risk goes up, we consider adding a second anti-HER2 therapy, which is referred to as Perjeta or pertuzumab. And those are both antibodies that are targeted only to tumor cells that have that HER2 feature. And it's been demonstrated in very large clinical trials conducted in this population of patients that by giving both chemotherapy and HER2-directed therapy, that you markedly reduce the risk of the disease returning and improve the overall survival of patients. The second component in this case is obviously leveraging the fact that the patient is hormone receptor positive. So any patient that has hormone-sensitive breast cancer, and by that again, I mean the estrogen receptor is present, we take advantage of that. And typically when the chemotherapy has been completed, even though the anti-HER2 therapy continues out through a year, we would add anti-hormonal therapy. This patient was peri or premenopausal at the outset. It's highly likely during the course of chemotherapy that her menstrual periods will become irregular, more likely than not stop. But we think about her, at least at the outset, as a premenopausal woman, and as such would typically start with tamoxifen as the anti-hormone therapy until we're convinced that she is indeed postmenopausal, at which point we switch to a different anti-hormone therapy. These are typically pills that are taken on a daily basis and continued for a minimum of 5 years, and in some circumstances continue beyond 5 years, all the way up to 10 years. And each of these things are additive. So the chemotherapy with the HER2 targeted therapy, as well as the anti-hormone therapy, each individually contribute to risk reduction. So you can't do one without the other if you want to optimize the risk reduction that can be achieved with systemic therapy. Most patients like this patient, as described, are cured of their breast cancer with the characteristics that have been described. And that's predicated on optimal local therapy, which Dr. King and Buchholz talked about, as well as the systemic therapy, which is a critical component as well.
Great. I think this is a very comprehensive discussion on this case, and a lot from all angles, local therapy, systemic therapy, hormonal axis being blocked, as well as HER2. So I think that this again underscores, and I would like to hear from you, Dr. Gradishar, the importance of multidisciplinary care and decision-making, because there are so many nuances in just one case that one could easily go astray and not do the best for the patient. What are your thoughts on that?
Well, certainly with respect to breast cancer care, it's highly dependent on people talking to one another to optimize the sequence of care. And as we go through other cases, the sequence of care may be different depending on the circumstances of the patient. So in other words, sometimes chemotherapy comes first rather than the surgery. Sometimes we have to integrate radiation therapy in select cases before we even get to surgery. So talking to our colleagues about each case is critically important to have a treatment plan that's tailored towards the patient we're seeing.
Thank you. Thank you for this excellent discussion. Thank you all.